Oh, hi everyone, it's Linda here from Just for Tummies. Welcome to our video, and I am delighted to welcome our guest, Lizzie Smith, who is a pelvic obstetrics and gynae physio and so much more. Lizzie has got so many strings to her bow. So without further ado, I would like Lizzie. Hi, Lizzie.
Hello, everybody.
I would like Lizzie to tell us a little bit about yourself.
Yeah, so hi everyone. Thank you for joining us today. So my name is Lizzie Smith. I am a pelvic obstetric and gynaecology physiotherapist, and I'm based in Nottinghamshire. I was born in Nottinghamshire, which you can probably tell from my accent. And
Mine too.
I'm resisting saying A up, mid up, but I'm going to be.
But we're proud of our accent, Lizzie.
Yes, we should be. And so I went to Sheffield Hallam University and qualified as a physiotherapist in 2010, where I began my career at my local hospital. I started in MSK physio, lots of hips and knees, lots of footballers with knees. And actually, when I went into women's health physio, that's when I realised that this was for me. And actually, the passion for women's health has kept me there. And I'm still working in women's health at my local hospital and have been doing for 11 years now. So I specialise in that.
You don't look old enough, Lizzie.
Makeup. Lots of makeup. So yeah, it's been a long stint, and I think I've always known I've loved physio, but for me, women's health physio wasn't a big thing back then. It was all MSK, respiratory, neurology physio, whereas actually women's health, when I went into women's health as a junior physio and did a rotation, I never came off that rotation. 11 years later, I still absolutely.
So was it like a light bulb moment then when you went on that rotation? You thought, right, this is for me.
Yeah, and I think for me it was really helping improve people's quality of life. And actually, with footballers and getting them back to football, there wasn't the job satisfaction for me. Whereas helping women,
they'd just go out and injure themselves again anyway, wouldn't they?
Exactly. So yeah, still there and doing it.
Right, and what I like about your type of, well, what you do is you help women through all ages of their life, don't you? And we'll come on to some of the work that you do, certainly with young mums, nipping things in the bud a little later on, Lizzie.
Yeah.
Right, okay then. So what does a pelvic obstetric and gynae physio do?
So back in the day, we used to be women's health physios, and when I first started, I was classed as a women's health physio, and then gradually over time we've turned into sort of pelvic health physios, meaning more the pelvic region and treating males as well as females, and now we are pelvic obstetric and gynaecology physios. So what that means is that obstetrically I treat pregnancy, which involves pelvic girdle pain, incontinence that starts in pregnancy, any MSK issues in pregnancy. I also treat ladies postnatally, and that's where we treat postnatal incontinence, whether that's bladder bowel. We treat traumatic births, so scar tissue management, pelvic organ prolapse, tummy gap. And then moving forward into the gynecology side, that's when we see ladies later on in life who may have had a prolapse for several years. They may have an incontinence for several years, and these patients have seen a gynecologist who's referred into the system. I also treat pelvic health in men. So we treat pelvic floor dysfunction in men, and I've also started treating transgender pelvic pain as well. So it's not just pelvic floor, it's actually so much more.
Very broad.
And that's why I love it so much, because it's just incredible. There's a
variety. 2 days of the same, are they?
Yeah, honestly, it's great, and everyone's so different, and it's the problem solving. And I think anyone that's been to see me will always say that I relish the problem solving and trying to figure out.
Well, I totally get where you're coming from there, because I am just the same. When it comes to digestive and gut health, for me, it's like being a detective, because it's not good enough that a person's got symptoms, and as you know, primary, secondary care, it's about treating symptoms. I want to get to the nub of the issue. What triggered the symptoms in the first place? It's interesting talking about pregnancy, labour, delivery. I was listening to Women's Hour on Radio 4, a few days ago, and they were discussing
Really?
childbirth. Yeah, it was a really. I was going to my mum's in the car. Actually, I always put Radio 4 on in the car. Well, Women's Hour. I
Great.
love Women's Hour.
Yeah,
And they
they're
were
great.
they were talking about episiotomies and how it was either 8 or 9 out of 10 women, Lizzie, have an episiotomy. And an episiotomy is where they have to cut the perineum. Is that correct?
Yeah, so they go down the side and out. Yeah.
To get the baby out.
Yeah.
Yes,
Yeah.
yeah.
And
But then these
unfortunately,
women, sorry.
the healing can be quite traumatic after that.
That's what they were talking about, the healing, and if it's not stitched up correctly, it can cause problems for women through the rest of their life. And there was a woman on there who she was an ex midwife, and she has developed a new device.
The new tool for cutting.
Well, it's not for cutting actually. It's a kind of more of a speculum that's inserted into the vagina, so that when they're stitching, when they're doing the episiotomy repair, so they can see properly and they can make a better job of the repair. She's a Danish woman, and she is the second midwife in the past 200 years to have developed a new device to help women when it comes to the vagina. The first midwife to develop the first device was the speculum. We all know and love when we're having our smears, etc. The second midwife in 200 years to have developed this vaginal device that helps with episiotomies. Anyway, Lizzie, we're going off.
Wait, we said we would.
We said we would. Okay, so I know you work for the NHS, but you also have your own very busy private practice. So what made you set up your own clinic?
So for me, I worked for the NHS, and I'll continue to do that forever because my heart is where the NHS is. Yeah. But following COVID and having to, I worked and did lots of phone clinics, and actually, how much can you get from a phone clinic? And at the time, it was great because it gave patients access to us. But what we found is a lot of them ladies were actually coming back round into the system post-COVID, and we were seeing face-to-face. And actually, when we assessed them, okay, this is why this has probably not been working. We need to work on this. So from my point of view, being able to offer people face-to-face appointments, but also postnatal ladies, the GP postnatal check, unfortunately, hasn't got the best reviews. And a lot of that went to phone appointments, and how are women supposed to get their C-section scar checked, their episiotomy, perineal tearing, just for someone to look. So I set up a postnatal service with the Mummy MOT, which we'll talk a little bit about in a bit. And that gives women the reassurance that they can come in and get everything checked. And the amount of women that walk out of this room and just feel like their shoulders are just weightless because they're not having to think and worry about, is my scar healing? Am I going to get any problems from this? Is the shelf normal with the C-section? Should it still feel numb? And the same with vaginal tears as well. No one really checks several weeks afterwards. So for me, setting up was mainly led by COVID and offering patients face-to-face reassurance, opposed to just phone call appointments, and also giving patients a long time as well, because we don't get the time in the NHS.
No, I know. So you set up your own clinic, and you can do all of these checks then for postnatal women?
Yeah, so we always say you need to have had a GP checkup first, just to make sure everything is okay, and then following that 6 to 8 week, hopefully, GP checkup, which hopefully is face-to-face, they can then book in for a postnatal check, whether that's just a tummy check, a pelvic floor check, a return to exercise check, or a Mummy MOT. They can get that access pretty quickly and that reassurance, and get started on their treatment and their programming and what they need to be doing.
Okay, so pelvic obstetric and gynae physiotherapist on the NHS. Is it quite challenging for a woman to get a referral to an NHS?
Yeah, and what we find is, and I think having two hats, sort of having my NHS hat and the private hat, is in the NHS we get ladies that have had symptoms for maybe 10, 20, 30, 40 years, that have finally finally been able to seek some help, but we get them a lot later. Whereas privately, we can get the ladies that aren't necessarily too symptomatic, but know something's not right. And they come for an assessment. And then we know if we can start rehab sooner, they get quicker and better results.
Oh, it's so important.
That preventative approach is what we need with women, opposed to treating it when it's been so long of symptoms.
And it becomes chronic, and then it can cause other issues, other health issues.
Yeah, and you can really see the contrast with that. And also, I think with the phone calls at the moment, having to ring the GP, having to speak to someone about your pelvic organ prolapse or about your bladder leakage or painful sex, to speak to someone over the phone that's a stranger, so many women won't want to do that. And the amount of ladies I get the email and say, it's really nice that I can just email you and tell you what's happening. And without having to actually speak. And I think that big taboo still is there. And I think that's a big barrier for women, where so many in my private clinic have said, it's great that you will email, I can talk to people. There's different means where people haven't necessarily got to speak to a stranger first to then speak to me.
I agree. And the thing with you as well, Lizzie, you are such a good communicator. You know, you have a lovely personality, and so people will certainly gravitate towards you.
And I think
you've got those great communication skills as well, which are very important.
Yeah, definitely for this job.
Yes, absolutely. And it's the same, you know, with digestive, certainly gut bowel health is that taboo that's still there. And, you know, we just need to be more open about these things.
We do. And I think, you know, the whole poo thing, I mean, on Channel 4, the recent programme about talking about poo and sort of gut health, I think poo is still a very taboo subject, and it doesn't need to be, because we all do it.
We all do it, yes. It's, you know, it's all we talk about in our house. Right, okay then, so can you explain what the pelvic floor is?
Yes, I can, and I've got some models
and then what it does, or do we cover that later? I can't remember. Anyway, what is it?
So the pelvic floor, and I think what we have to think about is how people describe the pelvic floor. So often people will come into clinic and say it's like it's a sling, it's a hammock, and this muscle it controls continence, and if it's weak, my organs are starting to move. And actually what I always do to ladies, and I'm going to show you my pelvic floor model, because I think when you see it, everyone just goes, wow, we didn't realize the pelvic floor was this complex. So this is the pelvis here. Okay, and then the pelvic floor muscles are all the red pink version. Okay, so it's not just that little sling that people talk about. And I think when women see this, they go, oh gosh, okay, this is a complex network of muscles that attach from the pubic bone at the front here, and they attach all the way down to the pelvis and into the coccyx. So we also have attachments into the sacrum. And as we rotate round here, we can see we get muscles into the hips and into the glutes. So it's not just a muscle that you squeeze and relax. It's actually a really complex network of muscles, because the pelvic floor has so many jobs to do. And that's why I love it as my favorite muscle group, because it is so complex, but it's the most underestimated muscle group in your body. And I think showing people this, they go, wow, actually, there's a lot of pelvic floor muscles and the attachments into the back and the hips as well.
You know where I can see those two holes there? Is one for the urethra, the vagina, and the rectum? Is that what I'm looking for?
I'm trying to get my camera right here. So we've got the urethral hole is just at the top here. We've then got the vaginal opening here, the perineal body, the perineum, and into the back passage here. So your pelvic floor muscles form part of your back passage and your front and into the urethra here. So these muscles here, your puborectalis, your pubococcygeus, and it's all to do with the position in the pelvis. So when we think of pelvic floor contractions, what we're aiming for is a nice contraction of the muscles here up and in. So when we look here, it's not just I'm just going to quickly squeeze down below, squeeze everything else. It's actually muscles in the pelvis here.
That's amazing. So they're not just kind of longitudinal muscles, the circular muscles, aren't they?
Yeah. So what I tend to say to ladies is the circular ones here are your sphincter control muscles. So they're the ones that really need to hold and control the sphincters. Whereas the deeper layer, which we can see just here. So if I bring this to the side, you can see there's a bit of a gap, and then you can see this deeper layer here. And this is the diaphragm. And this is the one that holds and supports your pelvic organs, is responsible for your posture, core, respiration. So it's a lot more than just squeeze your bits and hope for the best.
Well, I know when I had my baby, which is nearly 42 years ago, we went, I attended postnatal classes. And, we were told about squeezing and releasing wherever you are, whatever you're doing, whether you're sitting, standing, walking, squeeze, release. But obviously, having gone through the menopause, I did notice that my pelvic floor was getting a bit weaker. And I was maybe when I was coughing and sneezing, having a little bit of an accident. But Lizzie, since I started going to this ladies only gym that I've been going to since last May, and we do a lot of core work. It has so improved, so I'm no longer getting those accidents and no longer waking up in the middle of the night needing a week.
Yes. And that is what you've said is spot on. I think when I first started women's health, it was very much pelvic floor, squeeze your bits, quick squeezes, long squeezes, squeeze all the time. Whereas actually the pelvic floor is just the base. We also think about the diaphragm and the core that attaches around into your pelvic floor. So there's more and more evidence now for core exercises, Pilates-based exercises, really help work above the pelvic floor as well, because the pressure that's going down, that also needs to be managed by what's happening above. And I think that's how women's health, pelvic health has changed. We don't just look at the pelvic floor now. We look at, are you breathing correctly? Are you bearing down when you're exercising? Because that can all impact. So I think prehistorically it was all pelvic floor, but we forgot about what was happening here. But now with more evidence and research, we know that the core massively impacts this. And how can we train that? So like you said, you've been doing your core and that's made such a difference. So together.
Now, and I'm just going to digress very briefly here, but on the same subject. Been speaking to one of the ladies at the gym, and her daughter is having issues. Right, she can't have a cervical smear because they simply cannot get the speculum, even the smallest speculum, into her vagina. And so that could be something to do with those muscles, couldn't it?
Yeah. And what we tend to find
to gynaecology.
And it might be that previously we always think of the pelvic floor as lax and weak, and actually there's two categories. The pelvic floor can become lax and weak, or it can become overactive, which we're finding more and more now that women are doing too many Kegels or gripping and holding too much, especially ladies that are fit and active as well or younger. And actually what happens is the muscles become really short and tight, and that will still become a weak muscle because your bicep, for example, needs to be able to lengthen and relax to create a full contraction. Whereas if we're guarding our muscles or we're overdoing Kegels, that muscle will get really tight, and that will cause symptoms, for example, with examinations, painful sex, where using speculums or anything to do with insertion of tampons can become really, really painful.
Yes. And I suppose the same applies to the urethra as well. If the urethra is getting too narrow, so it increases the risk of a UTI because they can't expel all the urine, that could be down to a tight pelvic floor muscles. Hypertonic pelvic floor.
And we often find that with that, I will see patients from urology where they're unable to fully empty, maybe have to do intermittent self-catheterization, and we have to teach them pelvic floor relaxation, breathing techniques, how to void effectively, and how not to bear down to empty the bladder, and actually how to relax and breathe into the belly. And because the pelvic floor needs to be able to relax for your urine to come out nicely. And if the muscles are out, if it's tight, you're going to get that buildup of pressure. It's going to cause pain, and we're not going to be able to fully empty. So we really underestimate actually what an overactive, a tighter pelvic floor can do to the system, as well as a weaker pelvic floor. And it's nice now that as physios, we put back, we go, right, your pelvic floor is going to be either this and this, or this treatment pathways. And a lot of older school physios will just go for strengthening, but actually you need to really problem solve which route you are going down, because if you strengthen already a overactive pelvic floor, symptoms will increase. And
of course.
And
do you find as well, so do you find, you know, if you're working with a woman who's quite anxious and stressed for whatever reason, that can affect the pelvic floor as well?
Massively, yeah. And they did a really good research study where they inserted vaginal probes into women, and they exposed the women to different stimulation. So it might be comedy, romantic movies, pelvic floor nice and relaxed. And then when they showed them horror, anything that could increase adrenaline, what they found is that the probes were naturally being squashed. So that shows that pelvic floor reaction with stress. The same as that, if we're stressed, we're here, our pelvic floor can also gather, and having that awareness of letting go and relaxing, especially on the toilet, is key. And, you know, really sort of when you're on the toilet, being really mindful that you are relaxing and releasing, because your sphincters won't relax if your pelvic floor is so tight and overactive. And then that affects bowel and bladder.
I suppose breathing, you know, the breathing exercises that you do with these women, they help too.
Yes, definitely. Lots of diaphragmatic breathing for relaxing, or 360 breathing. So it depends on what patient's in front of you. But normally, if it's an overactive pelvic floor, we want to be focusing on lots of nice diaphragmatic belly breathing, closing the eyes, relaxing the pelvis, relaxing the pelvic floor. Whereas someone that might have a bit more of a lax pelvic floor, we want to try and manage pressure better. We'll do more 360 breathing. So it depends on who's in front of you as to which route you'll go down with your breathing patterns, which is great.
When you say 360 breathing, what do you mean? I understand diaphragmatic breathing, but what's 360?
360 breathing is being able to take the air into the side of the ribs here. So a lot of the time when we're stressed, we breathe, we do this.
Yes.
And actually, we're not
shallow breathing
to here. So what I always say to my ladies, you should be able to place your thumbs behind and the fingers at the front. As you breathe in, you should feel your ribs pushing your hands out.
Yes, I can feel that.
And then release. And then what you need to do is check that as you're doing that, you're not pulling your belly in. So placing a hand onto the belly and onto the ribs, and just feeling expansion in both. So rib expansion and belly expansion. And that is a great breathing technique for our ladies that have prolapse or have laxity, because we don't want them to take a lot of breath down onto an already weakened pelvic floor. We want that pelvic floor to manage pressure better. So we spread the pressure with the 360 breathing. Does that make sense?
That makes total sense. Thank you for that explanation.
It's great. And actually, it does help with acid reflux as well. So there's a little bit of it.
Oh, don't get me talking about acid reflux.
Breathing.
I'm contacted nearly every day by people who suffer with acid reflux.
Yeah, there's more and more evidence for breathing with that.
Well, we can talk about that, do a video about that another time.
We must.
So moving on, because we've got lots to get through, haven't we? So, right, this one then. Yes. So young mums come to you for help after childbirth. What symptoms do they display, and why is it important to nip these symptoms in the bud?
Yeah. So with the postnatal checkup, what we tend to find is a lot of the emails where ladies are struggling is that they might find that their bladder habits have changed postnatally. So I'm going to the toilet more than I used to. I can't hold as long. On the way, I'm getting dribbles. I'm sneezing and coughing and having some leakage. I've started back doing some impact and I'm getting leakage. Or we can have impact of pelvic floor with pressure. They report heaviness. Feeling it just doesn't feel right, and that's normally what I get on the email, that there's something there that wasn't there. Things feel low and heavy, compared to what it used to be like, and that's the big comparison. It doesn't feel right for me. And I think
can I ask a silly question, Lizzie? Sorry. So you know this heaviness, this heaviness feeling. I never experienced it after childbirth, but can a woman kind of feel heaviness kind of anteriorly at the front and posterior? You know, so maybe that would relate to bladder or uterus, and then posteriorly at the back that would maybe relate to rectum.
Yeah, definitely. And what you tend to find is that postnatal ladies will feel the heaviness more vaginally around the perineum. They'll feel
Yes.
bulkier there than normal. And they'll say when they wipe, they can feel that heaviness.
Yeah.
If you're thinking sort of more rectal, they're your ladies maybe later on in life that have had years of constipation and straining, that have a history of hemorrhoids, anal fissures, and they report the heaviness in the back passage, and they can really feel that heaviness when they're sitting. Whereas with more the frontal, it's more with walking, the pressure that they feel at the front and the perineum, more towards the bladder with the uterus compared to the rectal. So you'll often find that you'll find that the rectal ones there'll be different things that they'll say compared to sort of the vaginal. But also you can get a rectocele, which is a posterior wall, and that can be the symptoms of I'm going to the toilet and I'm having to splint to empty, and I'm just having to insert digits into the vagina, and that's a different type of prolapse. So
that's right. And I know women have told me over the years, certainly when I was, doing lots of colon hydrotherapy in the clinic, that they sometimes had to use the fingers to empty themselves.
Yes, yeah. And when you're, women's health are really good at questioning and really trying to delve in as to what your bowel habits are, because a lot of women will do this. They won't tell anyone they're doing this, but it gives us a really good idea of, okay, if someone's having to splint their perineum or use digits, that's telling me, okay, that posterior wall's probably not quite functioning as it should be. Or if someone's having to hold the back passage more, is it that a rectal prolapse, or is someone having to hold more at the front of the vagina? Is that more of a bladder? So everything we ask, we're asking for a reason. And again, it's problem solving, so we can start to sort of figure out.
And I just think they feel embarrassed, or they feel ashamed that they're having to do these procedures, to get the stool out. So it's great that there are physios like you who are very approachable, who they can contact and have a chat about it.
And actually say it's common, but it's not normal. But we talk about it all day, every day.
It's common, it's not normal, and let's try and fix it for you. So have you got anything else that you want to say about why it's so important to nip these issues in the bud?
So really, really important is, we know that symptoms, the longer we have symptoms and we suffer with symptoms, the harder it is to sort of start rehab and that rehab to work. And what we know is, 1 in 3 women will suffer with some sort of pelvic dysfunction in their lifetime. And as we go through life, so unfortunately, as we hit menopause, if there's already a weakness or an issue with your pelvic floor or bladder symptoms or bowel symptoms, menopause unfortunately will bring that to the forefront because of the change in the lack of estrogen. The pelvic floor muscles, the pelvic floor walls become we get atrophies, we get dryness, we get more brittle, it gets tighter. That can affect the bladder. We know there's estrogen receptors within the urethra. Menopause really does highlight any issues. So if we can nip things in the bud and see ladies before and say, right, this is what we need to be doing, then it will help through menopause massively. And
educate them and create more awareness around pelvic floor health and bladder health, vaginal health, bowel health.
Yeah, and we do get so many ladies that will say, oh gosh, if this is what I'm like now, I want to make sure I'm in the best possible place for when I hit the menopause, and for aging as well, because of collagen and the changes in collagen, that I need to be actually getting my pelvic floor to where it needs to be now and maintaining that. And it's the maintenance that we need. That is the key.
Yes. I know women can use pessary rings, can't they, Lizzie, if they've got a uterine prolapse. But the thing is with pessary rings, this is what I found, that they can introduce bacteria and cause UTIs.
Yes.
And I know one lady in particular. She was an elderly lady, and I said, well, you don't need your uterus anymore. It's giving you all these problems. Why don't you think about having it removed? And she did, and she felt a lot better.
And it's weighing up the pros and cons, and the risk. There is a risk with more pelvic floor dysfunction following a hysterectomy, just because the uterus isn't there. The bladder and bowel go, this is great, we've got a little bit of room. But as long as women are doing their pelvic floor exercises after that, then that's great.
Yes.
But also, yeah, you know, pessaries are great. There's such a place for pessaries, but it has to be right for you. And if you're getting lots of infections, urine infections, you're not able to empty the bladder properly, and that's leading to UTIs, then management really needs to be looked at. And I'm a big believer in everyone is different, and it's what works for you, and weighing up your pros and your cons.
Absolutely.
So you know which route to go down, but it can be great.
Yes, yeah. Right. So can you explain a little about the link between pelvic floor muscles and urinary tract infections? And because I have lots of women contact me who suffer with recurring UTIs.
So we're going to go back to what we spoke about a little bit about sometimes with urine infections, it's because we're not emptying the bladder properly. Now, is that because the muscles are weak and we have a prolapse, so the bladder is sitting in a different position, so the urethra is more kinked, and actually there's a kink in the urethra that's stopping fluid fully emptying? Or is it because the pelvic floor muscles are tight and overactive that the women are not able to empty their pelvic floor, empty their bladder because of their pelvic floor? So again, you're looking at both sides, and we'll be looking at the ladies that have a weaker pelvic floor, potentially a cystocele, so a bladder prolapse, a urethrocoele, a urethra prolapse, or even the uterine that's impacting the bladder. We'll be looking at their pelvic floor strength. Do they need to strengthen their pelvic floor to lift, to allow the urethra to be straight so that actually urine can flow through and we're not going to get any stuck and any infected? Or do we treat our overactive ladies with lots of breathing techniques, lots of relaxation to empty? Because as you know, if you're already sat, we're going to get bacteria, we're going to get infection, lots of UTIs, and UTIs over time can cause discomfort and pain, and that can actually lead to an overactive pelvic floor. So we know there's a link between chronic UTIs, chronic thrush, chronic BV, that because of the pain, the pelvic floor muscles become quite guarded. So chronic UTI can be a sign that potentially things are, that you've got a tighter pelvic floor, especially in younger women.
Yes, I suppose you take into consideration as well, you know, the bowels and transit time, and whether or not they suffer with constipation, because we know that can affect the bladder and increase the risk of a UTI, because you know, the feces is pushing. The bowel's pushing into the bladder, and so the bladder can't empty properly.
And I think we underestimate that space. And I always say to ladies, I'm always like, look, this space, there's not a lot of space for your pelvic organs to sit in here. If you've got slower transit and you're really impacted, constipated, the pressure on the bladder from the bowel, and if you've got a rectocele and some pelvic floor weakness there as well, or you've got a bowel and a bladder prolapse, the pressure. So often women, that link between the two, that actually once I've emptied my bowel and I'm managing my bowel better, that will help my bladder. And it's, you know, we can't talk about poo without talking about wee. We've got to talk about both.
So, you know, when it comes to assessing then if a woman has got a weak pelvic floor or a tight, you know, hypersensitive pelvic floor, how do you go about determining which one she's got?
So what we do when we assess the pelvic floor, we do a digital vaginal examination. So we don't use any speculums. It's a digital vaginal examination. And the same as any physio when we're assessing muscles. So for example, if we're assessing the shoulders and up into here, we're feeling, is the muscle soft and squishy? Is there a pain response? So I'm prodding here, soft and squishy, no pain response. Can I contract and let it go fully? Yes, I can. So what we look for in the pelvic floor internally, so this is my little pelvic floor here. So we've got the pubic bone at the front and the coccyx at the back. What we do is we insert and we assess the muscles here. So the same I've just prodded here, I'm doing exactly the same. I always say this to my ladies and show this, that we're checking the muscles here. So what I'm going to ask is, does this feel soft and squishy? They should say, yeah, I can feel a bit of pressure. Is it really squishy to the point where I can press and there's a lot of laxity in there? Or is it, can I feel a tight band underneath that when I press causes pain, and you'll see, oh gosh, that feels really tight, that's pulling. And then your head's thinking, right, okay, this is a tight muscle. So then what we get them to do is do a pelvic floor contraction. So we ask them to do a pelvic floor contraction. We'll then guide them how to do one properly. So engaging, so imagine you're holding and pulling a marble up into the back passage.
Yes,
marble.
I'm doing this now. I'm doing it now. Yes.
I found the marble seems to be the best one to describe, because if we say hold winding, what women do is they go and they squeeze everything else. Because
Yes.
you think, I'm trying to hold up. And if we say hold a wing, everything else seems to squeeze in. So what I tend to say is, imagine you're pulling a marble up into the back passage, then letting it out.
Yes.
Pulling up and letting out. So that's your quick one. So you're pulling it up, you're letting it out. So you're doing a bicep curl and you're letting it out. And then the slow ones that we feel for is that you can slowly pull that marble up and in, and then hold for 10 seconds, and then slowly release down. As you're doing these movements, we are checking that we can.
You're having a good feel around, yes.
And you'll know straight away, because sometimes you'll feel, and ladies will go, am I still holding? And they've probably let go at 2 seconds. So you'll know with your weaker ones.
2 seconds is a long time, Lizzie, isn't it?
It is.
I'm trying to hold it.
That is exactly the face that we make when we're doing. And it's always that face. And what we check for is that, and when I'm assessing ladies, I'm always looking everywhere else, because some women will use the neck to squeeze the pelvic floor. Some will breath hold. Some will try and do a bridge. There's all sorts of different techniques that women do. So when we're assessing, we're looking at absolutely everything to make sure that only these muscles are kicking in.
Well, yes, you want to make sure that they're doing it correctly, so that you can make the correct diagnosis, of course.
Yeah, and everyone's muscles are different. So if I'm assessing and it's really painful, short and tight, I'm not going to give lots of Kegels, and we're going to go lots of pelvic stretches, lots of diaphragmatic, lots of yin yoga, lots of relaxation techniques. If it's weak and we're really struggling with activation, we're going to go lots of isolated Kegels. We're potentially thinking about using machines to get the pelvic floor stimulated. So it's a very different route from the assessment that we do digitally. And that's why that assessment is so important, and seeing someone face to face is important, because we can start to problem solve from what we're talking about, but until we assess the pelvic floor, we just don't know.
Can I just ask you about digitals and rectoseals? Can you actually, I suppose it depends how severe the rectoseel is, but if you do a rectal digital, can you actually feel the rectoseel?
So what we tend to do for a rectoseel, so when we're assessing, we go into the vagina and then we will palpate the posterior wall. What you'll tend to find is with a rectoseel there, you'll feel this bulge, and you can often sometimes feel feces, so you can feel stool in there. And I'll say to ladies, when was the last time you emptied? And it might be, it's been 2 days since I've been to the toilet, and you can feel the pocket, and they'll say that I've probably been and let a little pebble out, type 1 stool, but I can feel that it's there. So often when you are examining, you'll know straight away. And if you get ladies to strain or bear down, you'll feel that lift or even sort of move forward. So posteriorly, we're checking. Anteriorly, we're checking for that bladder. Can we feel the cervix? But normally with a posterior, you have that big sort of lip here that when you press it down, you can normally feel this sat in there.
Yes, normally when women contact me and they tell me that women of a certain age, maybe 55 plus-ish, and they're telling me that they have a bowel movement, rabbit drop-ins, but they feel as though they haven't properly emptied. Obviously they haven't if it's just rabbit drop-ins. Then I say, well, you need to go and see your GP.
Yes, definitely to get that
seal.
Yes, yeah.
Right, so where are we? How are we doing for time? We're okay. So I just want to say, anyone that's watching, yes, this is Lizzie Smith, who is a pelvic obstetrics and gynae physiotherapist, and we're talking about pelvic health and yes, lots of wonderful things. So this one then, do women more than men suffer with a weak pelvic floor, and if so, why?
So the difference between men and women, obviously we've already looked at the pelvic floor earlier. So our pelvic floor as women is designed to carry children and for childbirth. So it's quite complex. It's a big network of muscles. Whereas a man's pelvic floor, it's not got to do that, because it's not got to bear children or push children out. So a man's pelvic floor is a lot thinner. I always say to ladies, it's a bit like this, except minus the front bit. So it's a very thin, thin pelvic floor, and it's more like the hammock that a lot of people talk about with the pelvic floor. So men's pelvic floor seem to be fine until they suffer with a enlarged prostate. So when the prostate is enlarged, the urethra runs through the prostate in them. So if it's enlarged, that's when we can get urine infections, or men will report that their stream is very stop-starty. They might have to strain to push to empty, and them straining can weaken their pelvic floor. So it could be related to enlarged prostate, or it can be related to men that have had prostate surgery. So if they've had the prostate removed due to cancer, there's a lot of trauma to the pelvic floor, and especially to the nerves. And we treat men for urinary incontinence and leakage during sort of when their prostate is there, but it's enlarged, but also post surgery as well, and that can take some time.
Do you mean nerve damage because of chemotherapy or radiotherapy? Sorry.
Yeah, radiotherapy, or from when they have their prostate removed. Even though we use a lot of robots now, and they're great, and depends on how much of the prostate, if the margins of the prostate, depends how much is being removed, and also what surgical procedure they're having done. We try and do more robot now because it's better for the pelvic floor and the nerves, and they'll always have physiotherapy afterwards, because we need to make sure that we get their pelvic floor working as soon as we can to stop any long-term issues with urinary incontinence and pelvic floor weakness.
What about urinary tract infections in men? Obviously less common than in women. Would the pelvic floor have some bearing on an increased risk of a man getting a UTI?
Yeah, definitely. So we often treat men with pelvic pain. So during the pandemic, a lot of people were sitting and working from home in really poor chairs. So there was a lot of more inflammation of the prostate, prostatitis, poor bladder habits, drinking.
Is that right? During the pandemic?
Yeah, so we've had more and more pelvic pain for men that have referred through, and an onset with UTIs, current UTIs, causing issues with emptying and then having to self-catheterize. So it is there in men. It's just that men potentially don't come forward and tell us. That's the problem. And we have men that have had years and years of symptoms, and actually it's because there's something else happening. So they sat on hard seats, even thinking about men that work in tractors and diggers, that
vibration,
and how that impacts the pelvic floor, and then that will then impact the bladder emptying. So
would that tighten the pelvic floor then, that constant vibration?
That constant pressure, because the pelvic floor responds to it, will just keep, and you tend to find that with that group of men, that they can end up with a really sort of tighter pelvic floor. And then again, we same principle: relaxation, pelvic stretches. What are they drinking? What are they avoiding volumes? Are they sitting down to empty? Are they standing up to empty? Are they quite shy about the toilets? Is there any anxieties around that? So we do see men, but normally sort of later on, more related to prostate or to job and sitting positions.
Right. Yeah. Oh, that's fascinating. Thank you.
It's a whole new world of that.
What's your typical patient then?
So I would say in the NHS clinics that I run, my typical patient, it's either an obstetric patient postnatally that's had a 3rd or 4th degree tear, so a perineal tear, that is attending for physio to make sure that the scar is healing well, that their bladder and bowel is functioning well, there's no issues with incontinence, and that they've got good pelvic floor to support as they're healing.
Yes.
In my gynaecology clinic, it's more prolapse. Probably patients have had symptoms for 10, 20, 30 years, and incontinence for a long time. So they're the ladies that we get in that have, when did this start? Oh, it's after my first child 42 years ago. And then the symptoms have just got to the point where they just can't cope anymore.
Okay. So you on a daily basis in clinic then, in the NHS, can you move from obstetrics to gynaecology?
Yeah, so in the morning I do a pregnancy clinic, and that's all PGP, and then there'll be postnatal tears mainly, and then in the afternoon it will be moved to the gynae clinic, where it will be the referrals from the gynaecologists or the GPs for prolapse, long history of prolapse, long history of incontinence. And we do get the ones that are younger, or that they've just noticed and have managed to see a GP that's managed to sort of refer in. Yes, it's been a wait, and it is a wait at the moment, unfortunately, like a lot of places in the NHS, but we do get them as well. But there's a big difference between sort of my NHS caseload and my private caseload, because that's sort of your postnatal ladies that are struggling post-birth, or it might be ladies that have started menopause or perimenopausal and have started to notice a change in symptoms, and I thought I need to get my pelvic floor checked. So you do see that difference in clinics, which is great, because variety is the spice of life.
Wow.
So.
Yeah. Well, so, I mean, the most common symptoms they display, I think you've covered that, Lizzie. But talking about tears during pregnancy, and they talked about this on Women's Hour the other day. And tears are categorised grade 1, 2, 3, 4,
Yes.
4 being the worst. What's happened when a woman's got a grade 4 tear?
So when we think of tears, like you said, we've got a grade 1, 2, and then a 3 and a 4. So what routinely we will see all grade 3 and 4 tears. So the reason we see them, so the NICE guidelines for labour states that there is a risk of pelvic floor dysfunction with ladies who've had a 3rd to 4th degree tear because of the tear extending into the back passage. So when we think of a 3rd and 4th degree, oh, the bits come off here. So we think of that tear extending down through the perineum and then into the fibres. So a 3rd degree extends, we've got a 3A, a 3B and a 3C, which goes slightly a little bit more into the back passage. And then a grade 4, unfortunately, goes from the perineum through the anal sphincter and up into the back passage. So this tear, it requires a lot of rehabilitation. We need to make sure that these women are really looked after in terms of healing, no infections, that they're taking their time, that they're doing gentle Kegels, but mainly they need to get their bowel consistency spot on.
Yes, they do. For obvious reasons, yes. And if they're getting constipated, then that's going to affect the healing of the tear.
Yeah, massive. And I think in new mums, it's hard. So, thinking about fluids, thinking about diet. Are you taking initially any lactulose to help that transit? Are you using a stool under your feet to empty? So we do sort of, with the new mothers, we really have to be quite strict and be like, we must get you, because we need everything to return.
Their focus is on their baby, isn't it? Not on themselves.
Yeah, and it's the 4th degree. We need to make sure we're seeing these ladies a lot. And in the NHS, it's something that does happen. We have a protocol, and they are seen on the ward, and they should be seen by a physio several times afterwards until they're asymptomatic, or until their pelvic floor is at a good strength. And if they come in and say, actually, I'm absolutely fine, that's great. But does their pelvic floor reflect that as well? So we do make sure our 4th degree, because we need to make sure that everything, mainly the bowel, is functioning, so there's no risk of long-term fecal incontinence.
Yes. Just out of interest, if a woman has a 4th degree tear like that, do you ever involve the other family members, like the partner or mum maybe, to support the woman?
Yeah, and we always say that for appointments, and it's really nice because a lot of partners do come to appointments as well, which is great. And mums come to the appointments because they're normally looking after baby while we're doing the assessment. And I think it's important that they talk about it, because often people don't talk about a 4th or 3rd degree tear, and they feel really isolated. So we do try and encourage people to bring family members, so we can explain to them as well what's happened. But actually, we need to make sure this lady's keeping hydrated. We need to make sure that she's eating good fibre. She's, her stools are consistent. And I think the more people around you that know and can help and support you, the better, because it can feel so isolating. It can feel so isolating for these women. And a lot of other mums won't talk about this. So that's where we come in, and women really sort of, when they come to our appointments, it's their time to be able to open up about anything they're struggling with, or bring family and partners.
Well, I'm just wondering, I mean, social media is you know, it's great. Well, it's bad sometimes, but
Mhm.
most of it's great. I'm just wondering about, you know, like Facebook groups, for example, that can help women like this. I mean, do you know
Yeah,
of any?
there are.
Have you got a Facebook page, by the way?
Yeah, I've got a Facebook page, and there are perineal trauma pages, and there are actually a lot of perineal trauma. There's a charity as well. I can't remember exactly what that one's called, but there's quite a lot of charities based around perineal trauma and 3rd and 4th degree tears. And I suppose again, it's with pages, it's how people use those pages. People enjoy that someone else's experience, but then sometimes people don't necessarily share all the positive and share all the negative. So I always say it's how you use the groups and how you use social media.
Yeah.
But there are a lot of charity bases that really help with sort of perineal trauma, and midwives postnatal can direct to therapy and let's talk, and that's something that we've got to really recommend, and we're picking up on with our ladies as well.
I'm just wondering, like Mumsnet, I bet they have.
Yeah. Oh yeah, they'll be. Yeah,
I'm sure they've got a forum on. Yes.
Yeah, and again, I suppose it's how you use it, but it's great because if someone's been to see a physio, they're like, oh, I've seen a physio for my tear, and then someone goes, well, I've not, and it's like, oh, actually, you need to chase that up because you need to some physio for your 3rd or 4th degree tear.
Yes. Okay. Thank you, Lizzie. So on we go. How can a strong pelvic floor prevent prolapses, including rectal prolapses, rectoseals, and urinary incontinence? So
we've already spoke.
I think you've covered that.
Yeah.
All right. Okay. So moving on.
I knew I'd blab at some point somewhere else about another question.
Let's have a look. Oh yes. Can you explain a bit more about the symptoms of a rectocele? Helpful tips and tricks, and how the pelvic floor impacts rectoceles.
Yes.
So, I mean, the symptoms: rabbit droppings, constipation.
Yeah. So rabbit dropping type stool, they go to the toilet, they'll pass a few, and then they'll sit there and they'll think, oh, there's still more there, but it's not coming out. So that's when ladies might, but I said, sort of self-digitate, go into the vagina and press onto the perineum, or they'll go walk away, 10 minutes later, coming back to the toilet, and there's a few more because we've stood up and we've moved sort of the anatomy a little bit.
Stimulated a little bit.
And then the other symptoms are it's feeling it's that feeling of something there that shouldn't be. And my perineum feels a bit bulgy, there's a bit more pressure there. And also sort of that link between the bowel. So it might be that these people suffer with IBS, and actually, getting their stool consistency is so important here, because if we've got the rectocele, it's just going to sit in that pocket. So that's sort of where, when you come in, Linda, and you can talk about you're really helping people's gut health, because that is key. Because if your gut health is not there and you're struggling, you need to work on both. Because
that rectocele is just going to get worse. It's just going to get bigger, isn't it?
Exactly. And I think a lot of people come to us with rectoceles, and yes, we do the pelvic floor side, and we can go through using a stool to empty, so raising the knees higher than the hips to help open the back passage, release the pubic rectalis muscle, and prevent that pressure building up.
Right. No, I'm always talking about that. Either get a squatty potty. You don't even have to get a squatty potty. You can go to is it Poundland and get one of those little stools.
Perfect.
If you're training your little boy to pee, at the toilet, just a little pound stool.
Yes.
Makes such a difference.
Anything that you could, even if you've got a big toilet roll at the side of your feet onto there, so as long as the knees are higher than the hips,
put your feet on the top.
Or if it's a bin, just slightly put it on its side. And really elevating the knees, leaning forward, relaxing into the abdomen. So unfortunately, we love to just push and bear down because we want to get it over and done with. We've got a life, we've got to rush, but actually the bowel needs time. And we don't give it time, and encouraging ladies to really connect in, so closing down the eyes, really taking a nice deep breath into the belly to encourage everything to relax and release, instead of making all the pushing, bearing down faces. So toilet dynamics is huge. And
so important, and it needs to start early. I mean, our granddaughter Jessie, she's 3. She was 3 a couple of weeks ago, so she's we're toilet training her now. She's on the potty, she's going to the toilet, and And we want to make it, you know, as natural and normal an experience as possible. And so I said to my husband, my daughter-in-law, and my son, and I say, look, don't ever mention that it's smelly.
Yeah.
If she feels as though she's got to rush, that yes, just say you've got plenty of time, Jessie. You don't have to rush. Take your time, you know, and take some nice deep breaths and just relax. It doesn't matter. You take as long as you like.
Yes, that is so important.
And we've got no hang-ups in our house about toilets and poo, as you can imagine.
And like I say, starting young is so important. You know, the people that don't like using toilets or they hover on toilets, hover in. Your muscles aren't going to relax if you hover. And so many ladies will say they've had the best poo when they've been to a festival and the toilets have been awful, so they've squatted in the woods and they've said they've had the best poo ever. And
I don't think you can beat having a poo outside.
Exactly.
Providing there's no one watching.
Yeah. And they say festival poos. It's so funny. They'll always say, oh, it's really, is it normal that when you squat, it's supposed to feel, you know, you're just empty and it's great. And I'm like, yes, that's your normal dynamics. That we've moved away from. So, you know,
the modern toilet's got a lot to answer for, hasn't it, when it comes to constipation?
Definitely. And like you said before, you can't, with a Rectiseal, yes, you can do your pelvic floor side and we can work on with pelvic floor strengthening and breathing techniques, but you need to get your stool consistency correct, because if it isn't, we're really going to struggle. So you've got to work together with that, because it can just a vicious cycle.
And you know, Rectiseals, they're graded as well. Are they graded 1 to 4?
Yes. So we grade them depending on symptoms, but also how far the Rectiseal has descended. So when we're assessing, we're looking, is it below the vaginal opening? So has it moved up and out? Is it just at the vaginal opening? Is it a bit higher? So consultants tend to use that a lot, because that gives them the really good idea, sort of management wise. And the grade depends on sort of whereabouts and how low that is sitting and to the extent of it. So we sort of will talk about a Rectiseal, a Cystoseal, but consultants tend to go for more the grading side. And that's for when they're potentially thinking about pessary sizes, surgical interventions, any other thing that they need to use. But you'll hear the grading, and that can sometimes be used by consultants with that.
Yes. Right. So you're a certified pre and postnatal coach. So can you tell us a bit more about this?
Yeah. So I said I specialise in obstetrics, pregnancy and postnatal. So there's a lot of factors postnatal that we need to consider. So it's returning to exercise, breastfeeding, back supports. So what a pre and postnatal coach does is just that extra bit in terms of what do you want to get back to. So it's a bit more personalised. So do you want to go and run a marathon in 6 months? Do you want to get back to CrossFit at 8 weeks? Do you want to be able to go and do a weekly park run? Do you want to be able to start back to your Pilates? So it's making it really specific, so that if I've got a lady that, for example, wants to get back to CrossFit, we've got to think, right, what activities and what exercises do you need to build up on to get you back to there, and how we can personalize it for that particular person. So it makes it more individualized, that you can coach ladies through depending on their goals. So goal setting, and it's something I'll always say, what do you want to be doing? Where do you want to be at? And we can work towards that. And that's the coaching element, and looking at they're doing movements. So often, how would you pick that up off the floor? How do you lift your baby? Because mums have to do these repetitive movements all the time. So it's just coaching them on lifestyle and exercise, and just giving them a little bit more that's specific to them, and not just saying, oh, this is, there we go away and do your exercises. It's more individualized.
And so is that available on the NHS, or is that privately?
That's private, yeah. So I've trained through Girls Gone Strong and with the Mummy MOT as well. And then I'm trained as a corrective exercise specialist. So that means that we can really look at mums when they're exercising. So, for example, I've had a lady in today that's been struggling with doing mountain climber exercises. So we've gone through it, we've broken down the exercise, and actually we've made a few tweaks in terms of that, where to hold and what to do. And actually that
what is she struggling with, Lizzie?
So it's a mountain climber. So you go on all fours, and then Joe Wicks is famous for doing these, if you've seen the Body Coach, and he like pushes his legs out.
Oh, they're horrible.
Exactly.
You're on the floor, aren't you, doing it?
Yes. They're
Oh,
awful.
when I go to Fit Farm in Derbyshire, I sometimes
Yeah.
go there for a week, and they do it there, and it's my most loathed exercise.
That and burpees.
Yeah, burpees, yes, that's
Yeah, and
good.
I think we do, you know, it's nice to be able to say to someone, right, what are you struggling with? Let's get the mat out, and I spend that time with them, and it's great because then they go, oh right, that makes more sense now. I'll do it that way, and it gives them that empowerment that we shouldn't be stopping things. We should be adjusting and
Yes.
looking, and you know, because I think we're so good at saying, oh well, you do have a prolapse, you shouldn't be doing this, you shouldn't be doing that. You leak, well, just don't run or jump. Well, no, actually. How can we adapt this and progress this and work around it instead of saying no, avoid? Let's manage and adapt. That's what I tend to do with a lot of my ladies, even if they do want me to do mountain climbers.
Oh, I hate them.
No, I agree.
Right. So I emailed you, didn't I, the other day because a lady contacted me. She suffers with constipation, and as a result, she's got piles that have been bleeding.
Yeah.
So the gastro examined her, Lizzie, and she said the reason she can't empty her bowels properly is to do with the pelvic floor, but didn't really explain what that meant. But it did tell her to buy a squatty potty, actually, and to use suppositories. But she seems to think maybe she's got a rectocele.
Yeah.
So she wanted to find actually a physiotherapist like you who will be able to help her. And I know you gave me that link, didn't you, to that website that's purely for obstetrics, gynae, and pelvic floor physiotherapists, right? Isn't it?
Yeah.
And I wrote it down, and I can't find my post-it. Everything looks tiny, doesn't it? Everything looks tiny. It's chaos.
Yeah, so the directory, it's the Pelvic Obstetric and Gynaecology, so it's called POGP, and it's Find a Physiotherapist. So if you type it in
again, sorry,
POGP,
yes,
and then Find a Physiotherapist.
Find a physiotherapist. Yeah, I'll find it again. I'll find your email.
All of the physios that are registered under POGP, so as a pelvic obstetric gynae, will be on there. But you can also, so for ladies on the Mummy MOT, there is a practitioner directory as well, and that brings a map up, and it will show you all your local women's health physios, and it will link to their website. So then you can look and see if they just do Mummy MOTs or do they also do pelvic floor assessments.
Is that on the POGP website as well? It's a separate one.
You've got your POGP Find a Physio, and then you've got your Mummy MOT practitioner.
Is it called Mummy MOT?
Yes, yeah.
Mummy MOT what, sorry?
Find a practitioner.
Find a practitioner. Oh, right, okay.
And often it brings up even more women's health physio. So we tend to find the POGP as a mixture between sort of your NHS and your private. Your Mummy MOT brings up loads of women's health ones. So you've got lots of options to find someone, and you will find someone. And I think with that lady that you've said, I think a pelvic floor assessment now is really important, because does she have a rectocele? Does she need help and support with strengthening? Or is it that she spent so many years pushing and bearing down that the pelvic floor muscles are now guarding against that, and she's not able to empty properly? So she needs to be assessed by a physio who can really start to break that down with her and see which road she needs to go down in terms of treatment.
But physios like you, Lizzie, in private practice, pelvic obstetrics and pelvic floor physios, I bet they're as rare as hen's teeth, aren't they? Is there very many of you?
There's not. We are getting a lot more, which is amazing. And I know sort of around where I am, I think there's a few sort of Sheffield way and Leicester way, but it seems to be only me sort of around this region at the moment. And it depends what people feel comfortable and confident. I mean, I've always done women's health, whereas some have done MSK and then done a little bit of women's health. I think you have to be an expert in your field massively with gynaecology and obstetrics.
Pick a lane and stay in it. Yes, I agree.
Yeah, and I think and you've got to be up to date with the evidence as well, because women's health is changing, which is great, because we're doing more and more research, which we never used to, just because women wouldn't come forward for research. But now we know the importance, and the women's health and pelvic health is really evolving, and it's really exciting. And I think going forward, there will be more and more of us. So keep looking and searching, and just contact it for some help and support, like you do with yours, Linda. You know, people can message and be like, right, can I ask about this? What do you recommend? And I think that's so important that women talk and are able to sort of just speak to someone and find out where they can be signposted to, like you said, with the GP, etc.
Well, yes, exactly. So if a woman wants to contact you, I don't know, maybe she lives in Scotland, I don't know, she can't get down to see you face to face, so she can talk to you, or you know, you can do a Zoom call or something like that.
You can do Zoom, or I can signpost to a physio in Scotland. And there is, I know there's a few. So it's nice to be connected.
Right. That's great. I was going to ask something else then, and it's gone. Yeah. Right.
And it's whether you go to your GP and say, can you refer me to pelvic health? And yes, there probably will be a little bit of a wait.
Oh yes, of course. Yes.
GP, great, you know, and actually we do get a lot of referrals from GPs, which is fabulous. And you know, going to the GP and saying, actually, I don't want to pester at the moment. I don't want to see gynaecology. Can I just go and see physio first?
Yeah.
Just my pelvic floor, see if there's anything I can do here, and then have that route and that option available.
So Lizzie, how do women contact you then? Can you give us you know, the name of your website, your Facebook page, you know, your social media? Just how do women contact you?
So I'm Modern Mums and More Physiotherapy, pelvic health physiotherapy. So I'm modernmumsphysiotherapy.com, and that's my website. And there's sections for postnatal specifically, gynaecology specifically, mummy MOTs, and all the services that I offer. And then you can contact me either so I'm on Facebook, Modern Mums Physiotherapy, and Instagram, where I get a lot of ladies will normally at 3-4 o'clock in the morning they'll message. Really interested. So at 3-4 o'clock in the morning, ladies must be thinking about things, and then I'll get a message through sort of asking for some advice, or that they're struggling. So you know, messages on Instagram and Facebook, or you can contact me at modernmumsphysiotherapy@gmail.com, or through the website. So when you go onto the website, you can have a look, and then there's contact forms at the bottom. So that's what a lot of ladies will do, because you put your name, your contact, your email, like you do, Linda, and then I can reply to that and then start the conversation with ladies via email or phone, and just have a chat through where we think they need to go, whether actually do they need to come and see me, do you need to go and see a GP, do you need to see a gynae, and just that signposting, which often we're not given, and I think that's so important, that ladies can open up and talk to someone, and we can signpost them to where we think they need to be, like you said with the GP earlier.
Yeah, absolutely. So when I share this video on social media, I'll put your website above the video anyway, a link to your website, and when I send it out to my database, I'll also include a link to your website. Just going back to consultations with you, so if someone wants a face-to-face consultation or an online consultation, how long do they last, Lizzie, and what are your fees?
So at the moment, I say how long they last. I normally go over, and if anyone's been to my clinic, they'll know I'm a bit renowned for going over, because I'm a problem solver, and I want to get to the bottom of things and figure out what's happening. So normally an assessment for a new patient is around 60 to 75 minutes. It should be 60, but I often do run over. A mummy MOT is normally 75, and sometimes to 90 minutes, depending on what's happening. And each session, so different sessions, it's a little bit different depending on what we're looking at. So a mummy MOT, which is a full comprehensive assessment where we check pelvic floor, tummy, posture, exercise, absolutely everything. And then you get a full bespoke program and written report, that's £95. A normal pelvic health check and full assessment, that is £75. And if it's more a specific area, so if it's pelvic girdle pain more externally, then we look at an hour-ish, and that's £65.
Okay. And what's your waiting list like? Because I mean, you work for the NHS, don't you? So what's your waiting list like
At the moment, this week I'm doing 6 days, so I'm working Saturday to catch up a little bit.
Yeah.
So I'm in clinic. I work in the NHS Monday, Wednesday, Fridays, and I'm in clinic Tuesdays and Thursdays. And normally that's sort of 9 till 7 or 8 at night, depending how many patients I need to book in. And I try and get people within 2 and 3 weeks.
Yes.
So it's not long. And at the most, if it's 4 weeks, that stresses me out. So I try and manage people to get people in at 2 or 3 weeks,
Okay.
or contact with cancellations.
Well, I know how dedicated you are to your patients. And when they've had their initial assessment with you, when do you like to see them again for a follow-up?
So ideally with pelvic floor, we know that ideally within 2 or 3 weeks, because the first 2 weeks following a consultation, motivation is high and everyone is like, right. And then what happens is after that 2 weeks, 3, 4 weeks, 5, 6 weeks, we lose that momentum. And so I try and aim for every 3 weeks, every 4 weeks, or if we're on a maintenance, it will be 6 weeks. Some ladies will come every 6 months to get their pelvic floor checked. And that's a really good way of checking in and saying, actually, because then you're nipping it in the bud, like you said earlier, and we're just keeping the momentum going. Because the pelvic floor, we can't see it. It's life can happen, and then weeks can go by, and we've not done any pelvic floor. So it's nice that women also want to book in and have that check to make sure, is my prolapse any worse? Do I need to go anywhere else? Do I need to be signposted anywhere? So initially 2 to 3 weeks, then we sort of go on to 6 weeks, and then it might be 8 to 10, and then moving on to sort of months and months down the line.
Okay. Right. That's great. Thank you so much. I'm going to wind it up there. It's been absolutely fascinating.
Well, thank you for having me.
And, well, I can't tell you how grateful I am for, giving us your time, because I know how super busy you are. I can't wait to share this video, because I know so many women, like I say, of all ages. And I mean, for me, like you, it's prevention. It's
it really is.
It's getting women early when they're younger, giving them the education, the knowledge, the awareness, so that they don't develop these issues.
And recognise that it's not normal. Not normal.
Not normal. Yes.
I think we just live
so, massive thank you, Lizzie. And it would be great if we could maybe do a video on. I'm sure there are other.
We should do. Look, I mean, I have gone on to a lot of other things today, so I do apologise.
No, it's been fantastic. I've thoroughly enjoyed it. Thank you. You enjoy the rest of your day. All right, then. Thank you so much, and thank you everyone for watching. I hope you find this video as fascinating and as helpful as I did. Bye.
Thank you.